This. Oh, maybe. Hang on.
Okay.
Stop that. Your mic here.
Try this again. And I don't hear any feedback. Okay. All right. Good morning, everyone. Thank you for joining us this morning for the final meeting this year for the ARHOME, the Health and Economic Outcomes Accountability Oversight Advisory Panel. And I do still kick myself that we made such a long name, but we appreciate you being here this morning. And thank you also. I know we have Senator Irvin, who's on the Zoom. And if we have some any other members join us on Zoom, we'll let you know that as well.
Recording in progress.
So we want to walk through this morning around some of the new outcomes data and also talk through some of the plans for the next plan year as we work to finalize our agreements with the carriers. So appreciate your attention and work this morning and look forward to some good conversation. So with that, I'll turn it over to Nell Smith to begin our presentation.
Good morning. Everybody hear me? All right. I'm Nell Smith. I'm an assistant director in the Division of Medical Services within DHS. So an assistant director within Medicaid. I'm going to, let me see. Click this button and hope that it works. There we go. All right. So today we're going to go through some program updates, and we're also going to review the 21 performance metrics. A little closer. I'll try and talk louder. Okay. Okay. So we're going to first go through program updates. And the first program update that we'll talk about is very exciting to us. It's the Life 360 Home program, which we talked about in our last meeting. Getting a louder one. Okay. So the Life 360 Home program that we went through during the last meeting has since been approved by CMS. We were very, very excited to get that approval. And I believe Friday we got legislative approval on our state promulgation process. The last bits left to do are completing another waiver and a state plan amendment, and that is only needed for the women who are not in ARHOME, so the women who are in pregnant women aid category or parent, caretaker, relative, other Medicaid aid categories to participate in the maternal Life 360 Home. So it's just a subset of the participants for that program that we need the additional approval from CMS to do. We anticipate a January 2023 start date, and we've already received 2 letters of intent from interested hospitals, and those are in the maternal Life 360 Home. So we're also actively talking to hospitals on the others, particularly rural, and we're very hopeful that we can get that underway beginning January 1. So the next item to go over are introduction of changes in our copay structure. You may know that our home clients who are in a qualified health plan, so a Blue Cross plan or a Centene plan, who are above 100% of FPL, those clients currently in 2022 pay copays. Nobody else in our home does pay copays. So those folks in a QHP currently pay $13 a month in premiums. They pay $4 or $8 in service-specific copays. So like when they go to the doctor's office or they fill a prescription. And their copays are limited to $60 per quarter. The new the copay structure is a little more detailed. The clients will have no premiums, so the $13 premium will go away, and that is a requirement of CMS. The copay amounts will go up to $4.70 and $9.40 rather than the $4 and the $8. And copays will start while clients await enrollment in a QHP. So currently, when clients enroll in our home, there's a period of time where they go and pick a plan, and then they have to wait until they can actually enroll in the QHP. During that time, they're in fee-for-service, traditional Medicaid. And now we will be starting copays while they're waiting for enrollment into a QHP. There will be no copays for certain populations, including those under 20% of FPL. So in the 2022 plan, only people above 100% of FPL federal poverty level will be pay copays. Now, anyone above 20% will be paying copays, and those under 20% will be exempt. Medically frail, those are also individuals who are considered to have a condition that makes it better for them to not be in a qualified health plan, but to be in traditional Medicaid. Those individuals will not have a copay. There will also be services that won't have copays, including pregnancy-related services, preventive services, inpatient hospitalization, and emergency services. And then the quarterly copay limits, which are currently $60 per quarter, will change, will be the numbers that you see in the boxes based on their FPL. And then finally, family members who pay copays, those copays will count toward the individual's copay limit. It's a household copay limit. So if there are two adults in our home who live in the same household, their copays count towards the total max. So now we'll talk about performance metrics, but before we do that, I just want to point out we are required to put together this quarterly report for you. We've given it to you each meeting, but we're not going to be talking about it today, but I just wanted to point it out. There's some new data in there on utilization, QHP utilization data. So just wanted to make reference to it so that you know that it's there. So we're going to be talking about the performance metrics. The ARHOME statute calls on this advisory panel to review and make non-binding recommendations and provide advice about DHS's proposed quality performance targets. So that is what we are doing today. We had hoped to do it in September, but had some data issues from the carriers, and we're combining that today with your other responsibility, which is to review the carriers' strategic plans. So it's kind of a full day. So just for some context, in December of 2021, this body reviewed the 2019 and 2020 performance results for 23 health metrics. And during that meeting, we set the 2022 performance targets for 22 of those health metrics. One of them is a hospital readmission rate that we just wanted to make sure carriers stayed under a particular level. We didn't set an actual target for them. So in June of 2022, and I should point out that the 2022 performance target metrics, we're in that year now. We will know the results of those probably third quarter of 2023. So you'll be hearing the 22 performance metrics in hopefully the third quarter of 2023. So in June, we reviewed the 2019 and the 2020 performance results for the 3 birth outcome metrics. These metrics take a little bit more time because we have to combine our claims data to the birth certificate data at the health department. So we hope probably in the March meeting, we'll review the 2021 birth metrics. But today we're just going to set the metrics based on 2019 and 2020. And today we're going to be reviewing 2021 performance metrics for those 23 health metrics we looked at in December of last year. And we're going to set the 2023 performance metrics for those plus the 3 birth outcomes. So one bit of context to keep in mind is Health Advantage, which is a Blue Cross plan. 2021 was Health Advantage's first year participating in ARHOME. So for example, the first quarter, they didn't have very many clients at all as they were building their client base. So some measures also use longer time periods, beginning before the calendar year 2021. For example, breast cancer screenings, count mammograms, received as far back as October 2019. So we have excluded Health Advantage on that metric. And you'll see that with an NA. But you'll also see some kind of strange metrics from Health Advantage, and I think primarily that's due to it was their first year existing. Okay, so we have 23 metrics with new 2021 data that we'll present today, and I'm not going to present details on all of the metrics, just a selection of them, but all of the metrics are provided in your handout. We'll review the metrics in groupings based on the type of metrics that they are. And the first metrics are preventive care. There are 3 metrics in preventive care: cervical cancer screening, chlamydia screening, and breast cancer screening. And we're just going to review 2 of those. So this is the slide structure you'll see throughout. So just to orient you to the way this data is shown, all the metrics have the same structure. The data on each measure shows for each year. So black or navy, I think it's navy, is 2019. The gray bar is 2020, and the red bar is 2021. And we also have the 2022 target, and that's the line that goes across the top. Then we've grouped the performances by the total ARHOME program, and that includes both the individuals who are in a qualified health plan, but it also includes individuals who are in Medicaid fee-for-service, the individuals who are medically frail and are in fee-for-service. It does not include people who are waiting to get into a QHP. We also have each QHP's performance in the middle there. We also have broken it out by rural and urban areas, and we have it broken out by race. So this is cervical cancer. You can't see it at the top, but this is the cervical cancer screening. And this is the percentage of women ages 21 to 64 who were screened for cervical cancer. And you'll see ARHOME as a whole is significantly below the 2019 Medicaid median of states. That's 46% compared with nearly 57%. That's the Medicaid median. These statistics have worsened from 2019 to 2021, which may be related to the pandemic and an overall decrease in elective medical care. The rural and urban rates are similar to each other across the years. And Black women have better cervical cancer screening rates than white women. And I should also mention Dr. Golden is our clinical director, and he's going to jump in when he feels like there's something to add. So
Great.
yeah.
Question. Now, is this cervical cancer screening just
I
PAPS?
can't hear you very
Oh,
well.
sorry.
You can, yeah.
Is the cervical cancer screening just pap smears or pap smear and HPV co-testing both?
It's both. It's either, I mean, it's different for different age groups. So ages 20.
Yeah, I mean, this is well defined by different methodologies to what tests we accept by the paid claims. So that's kept up to date.
Okay, so it's a composite measure of both.
For women ages 21 to 65, either cervical cytology, a pap smear, or for women ages 30 to 65, a combination of pap smear or HPV testing.
Thank you.
Yep.
Just ask, you mentioned the possible effect of the pandemic. Just talk just a little bit about that. And I'm curious, like on this one, we saw, now, if I think back, we had, the most significant disruptions from the pandemic in 2020, continuing into 21. But here we see that decrease continue. 21 was lower than 20. Is that consistent with what you're seeing in the other areas, or is this one more unique in that?
And what you're seeing is consistent with national trends. So there are some other projects. So clearly in 20, there was close to about a 25% reduction in adult ambulatory visits, ER and ambulatory. And then in 21, it began to come, late 20, it began to come back up. In 21, began to go back toward 19 levels, but it's been a slow, steady improvement. However, that's part of the challenge. We certainly want to make sure that even with this change, that people get their preventive services, immunizations, that kind of thing.
Yeah, I want to echo that. This is the same pattern we saw at the breast care program. We had substantial about 20% decrease for both our cervical and breast care.
And this is true all over the country. It's not just necessarily Arkansas.
Dr. Bala, yeah, speaking of breast cancer screening, you can't see it, but that's what this is. So this is the percentage of women ages 50 to 64, 64 for our population who had a mammogram to screen for breast cancer. So while we were significantly worse than the national median for cervical cancer screening, we perform closer to the national median when it comes to breast cancer screening. 2019 Medicaid median for reporting states was 54.7. And I'll say that we don't have 20 or 21 Medicaid data yet. They've come out with a new portal, and so everybody is a little delayed in reporting their numbers. So the Arkansas women all rate, not just Medicaid, is 74.5% for 2020, and the national rate is 78.3%. That's all women, not just Medicaid women. So overall, for the three measures, oh, sorry.
On the breast cancer screening, the ages, it's 50 to 64. Is there a reason why those 50
There have been controversies about when to start breast cancer screening. So there are some entities that recommend starting like about 40, 45, or people with risk factors. So a lot of the classic quality measures start at 50, and there's a give and a take on that. So we're using what has been the standard quality measure for breast cancer screening that all the other states are submitting for comparative data. But yeah, there has been a give and take on that. But I do believe the CDC or the U.S. Preventive Services Task Force, I think it's still at 50.
It is.
But it may change over time.
the US Preventative Services recommend 50 and above, but 40 to 50, the recommendation is for the patient to discuss the risks and benefits with the patient and decide to have the screening.
There's lots of debates about true positives and false positives and necessary biop. It goes beyond the conversation for today, but we're using what are being used for national reporting.
Thank you. So overall, cervical cancer and breast cancer screening rates declined from 19 to 21. That again mirrors the national decrease in cervical and breast cancer screenings between 19 and 20. The chlamydia screenings, which we didn't show, were more stable during the 3 years. And one thing that we found interesting was Black women in our home had cervical cancer, breast cancer, and chlamydia screening rates that were higher than white women in all 3 years. In 2021, urban women in our home had higher cervical, breast cancer, chlamydia screening rates than rural women. So the next grouping is maternal and perinatal care. So as I mentioned earlier, we reviewed birth outcomes. In June, we looked at low birth weight, very low birth weight, and preterm births. And so today we're going to be talking about contraceptive care, the percentage of women who were provided an effective method of contraception. And we're going to look at it in postpartum women and then all women in between the ages of 21 and 44. So you can't see it, but this is postpartum women who had, those are women who had, those who had a live birth, who were provided a most effective or moderately effective method of contraception. And most effective methods are long-acting reversible contraceptives, LARCs, such as implants or IUDs, as well as irreversible surgical contraception. And moderately effective methods include injectables, oral pills, patches, rings, and diaphragms. So the ARHOME rates for this measure have again decreased since 2019. However, the ARHOME rates are better on this metric than the national median of states, where the national median is 41.6% compared with ARHOME's 53%. Rural rates on this measure are better than urban rates, and white women have better rates on this measure than Black women. This is the, this is I'm pushing the button, but the button's not working. Here we go. Okay, so so this is the percentage of all women ages 21 to 44 who were provided a most effective or moderately effective method of contraception. And I scaled this the same way as the previous screen to show you that there's a significant postpartum women are getting contraceptives at a much higher rate than all women. Just like for postpartum women, the ARHOME rates for this measure have decreased since 2019. The ARHOME rates are better than the national median rate. The national median rate was 24.5, but the ARHOME rate is closer to the national median than the postpartum rate. Urban rates on this measure are better than rural rates, but only slightly. And there's not as much difference between the urban and rural as there was for postpartum. Similarly, Black women have slightly better rates on this measure than white women, but the differences were not as significant as the differences among the postpartum women. There we go.
I have a question. Sorry. Hi, this is Senator Irvin. I have a quick question.
Yes.
Hi, this is Senator Irvin. I have a quick question regarding the contraceptive care. I know that we have purchased and made available LARCs through the Department of Health for our health units across the state. This LARCS is covered, correct, by all plans?
Yes.
Okay, and what about for women under the age of 21? Is it just then available for them through that are on Medicaid? Do we provide contraceptive care for women that are below the age of 21 on any of our Medicaid programs?
The answer is yes. And in fact, in our standard Medicaid program, we actually had an education campaign targeting college campuses, college infirmaries to educate the infirmaries, but also the students on those campuses about LARCs. And we started that, I guess, about 3 or 4 years ago or more. And so, yeah, we do make an effort to do that. There was a period where things like implants were underutilized. We wanted to make sure people were trained to be able to do that. And we had an education campaign with booklets and so forth. That was actually extremely well, had a big uptake on college campuses in the state. Do you have something you want to add?
Yes, Senator Irvin, I just wanted to add that we did just recently pass a rule with Public Health and Legislative Council to increase the cost or the price that we reimburse LARCs to wholesale acquisition plus 6%. That applies across implants, IUDs, and the Nexplanon type implants that go in the arm. And we are also looking at, Dr. Golden just went through an educational campaign. We're looking at additional educational campaigns with the same vendor around this issue to try to make sure that we're promoting contraceptives for all women in Arkansas, postpartum and otherwise.
So it's a specific, that reimbursement is specific for providers that are placing those implants?
Yes, ma'am. I think
Okay.
we looked at the insertion and removal costs as well, but then the actual device.
All right, one thing that I ask, I know that I had reappropriated some funding that we found available through our trauma fund to increase the budget for LARCs at the Department of Health. If y'all don't mind just checking on that to see where we're at with our level of funding to make LARCs available through our health units. I would appreciate that.
That sounds good. Dr. Bala?
Senator Irvin, that is
Okay.
true. So we have been working. Press.
You're on.
Okay. Senator Irvin, this is Dr. Bala Simon from the Department of Health, and we've been working with DHS in this initiative in moving some of the trauma funds to expand the availability of LARC through our local health units for even those under 21 years of age. So that work is progressing well.
Okay, great. Thank you so much. I appreciate that.
All right, just to sum up the contraceptives, contraceptive care continued to decline in 2021 compared to previous years for postpartum women and all women. And among postpartum women, rural women had better rates of contraceptive care than urban women, while white women had better rates of contraceptive care than Black women. And among all women, it's just the reverse. Urban women had slightly better contraceptive care rates than rural women, and Black women had slightly better contraceptive care rates than white women. So this group of measures actually assess the quality of care and for acute and chronic conditions based on hospital admissions and readmissions. And the assumption is that chronic conditions that are well controlled will have fewer hospitalizations. There are 6 conditions, 6 conditions that include measures such as hospitalizations for diabetes complications among patients with COPD or asthma. But we're just going to focus on one measure, and that's hospital readmissions. Oh, there we go. So this is the ratio of observed all-cause readmissions to expected readmissions among adults aged 19 to 64. And essentially a ratio of 1 means the actual number of hospital readmissions was the same as the expected number of readmissions based on characteristics of the patients. So a ratio under 1 means the performance on the measure was better than expected, which is why we don't have a target for this particular metric. Everybody in 19 and 20 was under 1. So we felt like as long as everyone stays under 1, we didn't need to set a target. I do think we will set a target of 1 this go around, just to say that we've set it in case anyone does go over. And by the way, we put all of these targets into the MOU that we have with the carriers. So that's the binding document for these metrics.
Nell, is this 30-day readmission?
Yes, sir. It's readmissions, unplanned hospital readmission that happens within 30 days of discharge from the initial admission. And expected, what we mean by expected is based on the characteristics of the index hospital stays, including the presence of surgeries, discharge conditions, comorbidity, age, and gender. So the 2019 Medicaid median of reporting states was above 1, so we're doing better than the Medicaid median. And Health Advantage, as I mentioned earlier, is a little weird in 2021 since it was its first year, and its ratio is sky high, but it's based on 2 people. So we just didn't show it here. And I already mentioned we didn't select a target for 2022, but we expect to do that for 2023. If I'm not pressing the button hard enough, here we go. So this is the hospital readmission rates. Worsened across the board in 2021 compared with 2020, but still we're under 1. We're better than expected. The admission rates, I mentioned that we had a number of other metrics. So this is giving you some of the insight on the other metrics, but admission rates for older adults with COPD or asthma and all adults for heart failure, readmissions for heart failure improved in 2021. Black clients had worse admission rates for heart failure than white clients, but better rates for older adults with COPD or asthma. And rural clients had worse admission rates for heart failure than urban clients, but better rates for older adults with COPD or asthma. So behavioral health care, there are 12 measures that we use to measure quality of care for behavioral health. And among them are drug and alcohol treatment, antidepressant medication management, adherence to medications for individuals with schizophrenia, and follow-up after hospitalization and or an emergency room visit. And we're going to review 7 of them. Some of them are related, so in fact, a lot of them are related to one another. So this is the percentage of clients with a new episode of alcohol or other drug abuse who initiated alcohol or drug treatment within 14 days of the diagnosis. So this is initiation of alcohol and drug abuse treatment. So it's within 14 days. The ARHOME rates are slightly lower than the 2019 national median. The national median was 42.7%. But the ARHOME rate has improved each year since 2019, and urban and rural rates are just about the same. But white clients initiate treatment at significantly higher rates than Black clients. At least the rates show that. So this is, as I mentioned, some of these are related. This is engagement. So the first one was, do they initiate? This is, do they engage? And so it's taking the same people who were in that last metric, and it says who stayed in, were engaged in ongoing treatment within 34 days of the initiation visit. So ARHOME is below the national Medicaid median of reporting states, which was 16%. And just like the initiation of treatment, we continue to improve in the engagement of treatment since 2019. And similarly, white clients are engaged in treatment at higher rates than Black clients. And
I was just going to say, from a historic perspective, this whole area about treatment has only been a staple in our measurement portfolio for a couple of years. So we were a little bit, if you will, slow, a little bit lagging in the feedback to the payer community and to our provider community. So we're making steady progress year over year. So this is all heading in the right direction and being, this is a good trend line that we'll see steady improvement over time.
So this is antidepressant medication management. This is the percentage of individuals diagnosed with major depression who were treated with and remained on antidepressant medication for 12 weeks. So this is in the acute phase, that's 12 weeks. ARHOME does slightly better on this measure than the national median rate. In 2019, the median rate was 51.3%. There was improvement on this measure each year since 2019. So this is, in the last two metrics, we saw a decrease, a significant decrease between initiation of treatment and engagement with treatment. And this one has a dip, but it's not quite as dramatic, so that individuals who are diagnosed with depression are staying on their medication. So this is the percentage of individuals diagnosed with major depression who were treated with and remained on the medication for 6 months. So the previous one is 12 weeks, this is 6 months. ARHOME does slightly better on this measure than the national median. The national median in 2019 was 37.3%. And there's little difference between rural and urban rates, but white clients had significantly higher rates of medication management than Black clients.
What proportion of these ARHOME programs offer counseling services for depression?
I believe they all
They all
offer.
work. I mean, that's all part of the standard package, so it'll all be part in there. And Medicaid as a whole, we're making, we have a focused effort about trying to integrate primary care with behavioral health and expand those kinds of services. So there's no structural payment issue in terms of getting counseling services.
Is there a copay for the counseling services besides that of the office visit?
Not besides the office visit. There would be a copay. I don't believe it's included in preventive care services. So I believe there would be a copay. And we can verify that as well. I don't know if you guys. Okay. Okay, so this slide is use of opioids at high dosages. And this is the percentage of clients who received prescriptions for opioids that were in dosages that were average daily dosages that were greater than or equal to 90 morphine milligram equivalents. And these do not include individuals with cancer, sickle cell disease, or in hospice or palliative care.
Just as an aside, regular Medicaid also has some of the lowest rates on this measure in the country. So we've had an effective program over the last about 7 or 8 years to focus on high dosage prescribing of opioids. And we've successfully reduced our rates to well below 1%.
And that leads me to the national median for 2019 is 6.5. So you can see we're at 1%. We do see some improvement in the ARHOME rate each year, with urban rates generally being higher than rural rates and rates for white clients being slightly higher than rates for Black clients. So to sum it all up, the initiation and engagement of drug and alcohol treatment improved each year. Antidepressant medication management in the acute and continuation phase also improved each year. Compared with Black clients, white clients had higher rates of initiation and engagement of drug and alcohol treatment. And they also had higher rates of antidepressant medication management in both acute and continuation phase. Rates of opioid use continued to improve, meaning they decreased each year.
Just a quick question, like with the contraceptive care education campaign, is there a campaign targeted towards mental health treatment that you guys offer? That
Paula, do you want me to take this one now, or would you
Sure.
like to? Okay, and I'm sure Nell can speak to the rural Life 360 home for mental health a little bit more than I can, but we do have that, and that targets individuals in rural areas who have serious mental illness or substance use disorder. As you know, we also offer our provider-led Arkansas Shared Savings Entity Program, which is for those with high levels of behavioral health needs. So actually, we are now moving our home clients who meet that criteria into those passes, and that allows them to receive intense care coordination. So someone actually follows their care and ensures that they get follow-up care. The other thing that we're doing right now, and you may have, if you would like to, we have a whole package on it. We just carried about a 10 rule package through the legislature targeting behavioral health services, particularly home and community-based services to support individuals with behavioral health needs. But we also included that in that some preventative behavioral health services, meaning access to a clinician at your primary care office, the ability for your primary care provider to do depression screens, including a pediatrician's ability to do a postpartum depression screen for a mother. We're looking at all of that and working closely with the Behavioral Health Network to make sure that Medicaid is covering those preventative behavioral health services as well. So I don't know that we have a strategic campaign yet, but we are putting all of that together. And the last piece that we're currently working on that you will see a more strategic campaign around is a statewide crisis system. That allows us to provide crisis systems or services to everyone in the state, not just Medicaid. So we'll partner with a lot of different organizations around that.
Might also comment about our use of telehealth, because telehealth psychiatry has really been a staple of our telehealth program. There's all sorts of great ways telehealth can expand the availability of counseling services in rural areas.
And I would just also add that the QHPs, about 88% of our clients are in a qualified health plan. And Matthew and Kim are going to be giving you their strategic plans for 2023. We encourage them to create incentives and address what they can to identify clients with a diagnosis within their claims and reach out to them and figure out what initiatives they can do to improve these scores.
You know, the other thing to keep in mind is another reason for a priority on this kind of service is that patients who are depressed generally have worse outcomes in things like diabetes and heart failure. So obviously, if we can address the behavioral health issues, that can also help on the physical side with in terms of managing chronic disease.
Yeah. I'm excited to hear about all the programs. There was a period during the pandemic when the qualified health plans waived copay for counseling services and facilitated telehealth counseling as well. I thought that was, several of my patients had really benefited from that because a lot of people with the lower socioeconomic status, it's hard for them to meet the medical appointments, but the no-show rates for the behavioral health was even worse. So waiving the copay and also facilitating telehealth for counseling was really a good thing during the pandemic. I was wondering is there a plan to continue that or in one fashion or other?
We've just revamped our copays, so we don't at this time. We're working with the copays that we've agreed with CMS to run. But what happens in the future is
Definitely something we can look at and talk to the carriers about, and I'll let them speak to what they've done around their telehealth policy when they speak on their strategic plans. Medicaid has made telehealth behavioral health services accessible through telehealth permanently as a result of what we found during the pandemic. And I would just like to add that Representative Vaught led a behavioral health task force. It lasted for about 8 months, I think. It was very long. And quite a few recommendations that I just discussed came out of that, as well as some others. So I think she put out a report that was presented to ALC last Friday. That's one thing to look at as far as what the state is doing around behavioral health.
Yeah. And there's a number of legislative pieces that come out of that we'll be addressing in the next session.
All right, these are the last three metrics that we have for, well, they're the last that we have, but last for mental health. And these are all follow-up metrics, follow-up after an ED visit, or an emergency department visit, or follow-up after hospitalization. And I'll just, we got late on Friday, some information that some data that was transferred from our data warehouse to our vendor that calculates our metrics. We probably are going to need to tweak these. So there's maybe, up to 5% increase that would come from some of these metrics, but it'll be very slight. But just wanted to.
And one of the things that we're working on with the Office of Health Information with SHARE is, there are mechanisms in place where when they get claims of ER visits and hospitalizations, they can feed that back to the third-party payers to alert them that there's been a visit, so that we can have administrative mechanisms in place. I don't know, Ann, if you want to make any comments or not, but that's also helping expedite and notify people of an opportunity for follow-up visits because of an acute care visit.
The only comment I was going to make, we still have several behavioral health hospitals. They're still on paper. They're not able to transfer the data electronically, but the Arkansas State Hospital and Methodist Hospital both have gone to an electronic medical records, but we still have several behavioral health hospitals in Arkansas that are on paper.
That was Ann Sandifer from SHARE. So this slide is showing the percentage of emergency department visits for beneficiaries in our age range with a principal diagnosis of mental illness or intentional self-harm who had a follow-up visit for mental illness within 30 days. So ARHOME generally does worse in this measure than the 2019 National Medicaid median of reporting states, which was 52.1%. The program has decreased each year since 2019, unlike other mental health metrics that we saw earlier. And rural clients had better rates than urban clients for this measure. And again, white clients have better rates for follow-up on this metric than Black clients. So this is the percentage of clients who were hospitalized for treatment of selected mental illness or intentional self-harm, who had a follow-up visit with a mental health provider within 30 days. So follow-up after hospitalization for mental illness, like the previous measure, lags behind the 2019 Medicaid median of reporting states, which was 54.7, but ARHOME has shown improvement since 2019. Urban rates are slightly better than rural rates, which is different from the last measure. But like the last measure, white clients had better rates than Black clients. And this is the last one. This is the percentage of emergency department visits for clients with a principal diagnosis of alcohol or other drug abuse or dependence who had follow-up for alcohol or drug abuse within 30 days. While we saw follow-up rates for mental illness in the 40% range, follow-up for alcohol or drug abuse are barely above 10%. The ARHOME program is significantly below the 2019 National Medicaid median of reporting states, which was 22.5, but the ARHOME rates improved each year from 2019, so we're on the right track. Again, as we've seen with other metrics for mental illness, mental health treatment, excuse me, white clients had better rates than Black clients.
A question.
Sure.
Oop, turn it off. On that previous slide, Blue Cross Blue Shield had a much better number. And on the other slide, there was, I think Ann had a better number that kind of stood out. I mean, are we looking at best practices there? Is there something that one of these, like Blue Cross Blue Shield, is doing that we can share? I'm not, this is competitive, I understand it. But why? Why is that? Do you know?
I don't think we know the answer at this point. We're just beginning to get the data in at the QHP level. We do hope that the QHPs they're going to present their strategic plans for addressing these issues. We're asking them to meet targets. So they're going to be telling us these are the incentives that we're putting in place, whether it's on the provider side or on the client side, to make improvements. And we also have an evaluation for the whole ARHOME program that will be looking at these metrics and the QHPs and what did they do differently.
So if we know that one provider is doing much better, do we know how we can use that as an advantage to improve overall? I mean, do we as an organization know what we can do to utilize those best outcomes?
Yeah, obviously. Well, first of all, comparative data helps drive a change, but also there are all sorts of things that we do as a program, getting more timely data to the payers for them to incorporate into their programs. Obviously, different mechanisms they have to then take that data and feed it back to providers and to patients and reaching out to patients. So yes, this is a long-term prospect, and we, obviously we'll be looking at the trends and try to improve. We also sit on national calls to hear what other states are doing with the similar data. So we're constantly looking to see best practices, not only in Arkansas, but in other states as well.
So just as the sort of overall slide, rates decline for follow-up after an emergency department or hospitalization for mental illness. Rates improve for follow-up after an ED for alcohol or drug abuse, so just the opposite. White clients had better follow-up rates than Black clients across all 3 years. And you'll remember that's the same for the other metrics, mental health metrics, treatment metrics that we saw. Rural clients had higher follow-up rates after an ED visit for mental illness and drug abuse than urban clients, but urban clients had higher follow-up rates after hospitalization for mental illness. So performance target setting. So we need to set targets for the 2023 performance year, and we need to do it before the end of December. So we've got a deadline, and there are 3 basic decisions that we need to make. What should the targets be for each measure? And what does it mean to meet the targets in terms of incurring consequences? Do we want them to meet all of the targets? Do we want them to meet a certain percentage of targets or something else? And what should the penalties be for not meeting the targets? So just for some consideration, as a reminder, our 2022 targets were set based on the rate of the best performing qualified health plan across 2019 and 2020. So we took the highest performer and set that as the 2022 target. QHPs are subject to a corrective action plan for failure to meet the 2022 metrics. As I mentioned, we won't know that until third quarter of 2023. So they'll be subject to a corrective action plan at that point. Considerations for 2023, we wanted to try and incentivize better performance among the lowest performers, as well as the high performers. And we thought about weighting some measures higher than some others. For example, those that are affecting more people might get a higher rating, higher weight. And those that are closely tied to our Life 360 home program, such as our birth outcomes. So this is our proposal. for target setting. We would set a point system for meeting the metrics, and we would tie the number of points each QHP receives to different levels of financial outcomes. So QHPs would receive 1 point for meeting the median rate. And you can see an example in the table below. We've got 5 plans and 3 years. So the median of those values would be our median rate. And then they would receive an additional 2 to 3 points for meeting the actual target, the best performer. So again, across 5 plans and 3 years, the best performer is the one in green. That would be the actual target. And they would get higher points based on that, meeting that metric. And we would be weighting those differently based on, as I mentioned, those that affect more people or those that are more closely tied to the Life 360 Home initiative. And a QHP that scores 50 or more points, total points, would have no financial penalty. Fewer points would bring increasing levels of financial penalties. So, for example, a QHP that scored between 40 and 49 points might receive a 0.5 percentage point off of our cost sharing amounts, which is a whole different thing, but it's about $2.5 million across the board is a 0.5 percentage point. So this is our proposal for setting targets and for constructing the consequences for not meeting those targets. The carriers, I think, are not exactly happy with this proposal and have suggested a couple of other ways of doing it. I think we're still in conversations about that, but wanted to put this out there to get the thoughts of the group.
Nell, can you talk a little bit about some of the counter proposals, just so this group can talk about those, particularly around the growth rates?
Yes, so we've talked about the carriers have suggested instead of meeting a hard target, meeting growth rates for their own measures. That has some appeal as we know in education, there's a student growth rate that plays a role. So the positives are it's allowing each carrier to reach a certain improvement point from where they're beginning. I think some of the negatives are we've got some Health Advantage, which doesn't have any of the birth outcomes. There are certain other metrics that we couldn't have for them because they were new. So one carrier wouldn't have anything to grow from for 23. There are other metrics where Health Advantage is kind of off the charts in a way that would make it very easy for them to improve. And maybe those cancel each other out, but that is the issue with growth. New entrants into a market, new QHPs present a problem for using growth metrics. So anything.
No, I would just say I think some of the main points under negotiation are how to weight these metrics, how to use growth rates, and then as well, I mean, what the point system should look like. I think the idea of financial penalties everyone's on board with, but what that point system should look like so that it's fairly applied, and then what the ultimate penalty would be. So those are the pieces I think we're still trying to finalize. I think the overall structure is kind of agreed upon. It's just some of those details. And so if we could have some discussion around that today, I think that would be most beneficial for us.
And then I have a question too. Thank you. So what, we're looking at the median here. What do we do in those categories where there's not 5, there's 4? Are we going to do an average instead on those?
Yeah, Excel is very helpful in creating the median for you. It does it in the middle of the even numbered.
Okay.
Yeah.
Okay. And then, again, maybe this is just a thought process that may or may not be valid. But when it comes to weighting these measures, I understand, I think the purpose behind doing that, but I would also say that sometimes it can kind of be a numbers game. And so if we've weighted 8 of these as a health plan, I would focus on those 8 and maybe pick 2 or 3 more, and the rest would fall off to the wayside. So I just kind of wanted to throw that out there, that if we do weight them, I don't know that they will all be given the same attention moving forward.
So you're picking the median or exceeding based on the current participating QHPs within Arkansas, right? We all look at the comparable other state QHPs to see, because here just comparing within the population served may have the same challenges, so you may not raise above that. So if you look at a comparison state like Mississippi or Tennessee, who have the same demographics like us, and look at their QHP plans, maybe we can raise a little above than the average.
Yeah, that's all part of the discussion process. And we've been having these discussions weekly for 2 years now. And, every Medicaid program in the country in 24 will have mandatory data reporting requirements to CMS. So we have that data. So, part of the priority setting, some of the weighting will take into consideration what's happening around us and what's happening in other states. So the national data, regional data are all available to us and to the QHPs to help with decision making and to look an assessment of where we are and where we're going.
Excuse me, the one thing I would add, and Elizabeth, you may want to chime in on this as well, is that while this is newer for the qualified health plans, we have been, when I think about within some of our other coverage plans, like with regard to the passes, we have been tracking and then also incentivizing or disincentivizing performance where appropriate over the really, I think, since the inception of the program. So I wonder if you want to just talk about that for a little bit.
Sure. I think there's a couple of programs you can talk about that in relation to, one being the PCMH PCCM program, where we do very clearly set metrics and incentives based on that. And then initially in that program actually had some disincentives, but now it's primarily incentive based. Also the PASS program, the metrics are very different for that program. We're looking primarily at some of those behavioral health metrics, particularly around our people getting services that we know they need to have, but we have in fact taken action against those passes when they're not meeting those targets or those metrics. And that is not something we have historically done in this program. It's just been designed differently, but this is a move in that direction to make sure this program is meeting the goals that we've set out for it as a state, just like we do within our other programs, and hold those providers and carriers accountable.
And this year, we also started looking at the national Medicaid submission data for our dental mental health, dental managed care plans as well.
And actually, to that point, Dr. Golden, they've always had metrics that we've held them accountable for. We have changed those to better align with national metrics, but we've always looked at things like preventative dental services and sealants, and it's been built into their contract since, I believe, year 1. So thank you for reminding me of that.
So the other way to look about this is, rather than comparing across, you can also do comparison of within them compared to the other states. Like Blue Cross Blue Shield, here contraceptive care is 27%. How do they rank compared to the other states? Maybe we are 48th. Maybe they can look at the neighboring state, they may be 34%. So you could set within, because there may be more flexibility within Blue Cross Blue Shield, Centene, within the plans.
Oh, yeah, of course, you have to remember, you see one Medicaid program, you've seen one Medicaid program.
Yeah.
Mississippi, you brought up, has yet to expand Medicaid expansion. In fact, I was at a recent meeting and people from Mississippi were coming up to me to say, how did it work for you guys? Was it a good deal? Was it? So, obviously you have to take everything in context. So
Yeah. Okay, thanks.
I would just add that the Blue Cross that we're talking about is Medicaid Blue Cross, not necessarily Blue Cross, of upper incomes. And there are slight differences in the way that we calculate the metrics as opposed to the insurance companies. So there's a little bit of apples and oranges there.
Maybe y'all do this, but we're talking about looking at states regionally, which is great. I think we need to do that. We talk about national average, but do we look at the best states? The old saying is, it's hard to fly like an eagle if you're flying with a bunch of vultures. So, and I don't mean that negatively, but we ought to be looking at the eagles, right? And maybe y'all are doing that, but I don't think we should get tied into just looking at the people around us. I understand the environment's the same and some of the, the work environment, all that's the same, but we still need to be looking at those best states. There may be things that we could incorporate.
we throughout DMS, folks are part of national consortia. So I sit on some calls, and I know our pharmacy group does, and we hear presentations from other states all the time about best practices and things that work. Now, sometimes some of the things that they bring up are not within our resource, basket, or they have unique circumstances or unique state laws or regulations. But we are regularly listening to presentations, and sometimes we're the ones giving the presentations because we've actually done something better than other folks have done. So, it's variable, but yes, we're constantly looking.
And I'll just add and echo a little bit of what Dr. Golden just said. We are looking at the national average, so trying to make sure we are in line with where everyone is, including those best states. But to Dr. Golden's points, we are resourced very differently than a lot of other Medicaid states that maybe have some of those really good metrics, like a Colorado that has a lot of private dollars from selling marijuana that we just don't have. So they're able to do a lot of different things because they're not tied to those federal regulations like we are. So we just have to be careful in that comparison. We definitely look. I know we borrow ideas from other states all the time, but we do have to be careful in trying to hold people accountable immediately for trying to meet some metrics in states where they just have a lot more resources than we do.
Yeah, well, I understand that, but if we're talking about resources, especially if we're talking about private resources, we should not discount our state because if that's an area that we're failing in, then we ought to know that and be looking at that. We've got some of the largest corporations in the world within our state that we might be able to get resources from if we knew that's a big problem. So, we need to find out what it is, even though we may be limited. And I think about you mentioned laws. Some of the other states have unique laws. Well, we as a legislature, I think they would agree with me, we're willing to work on anything, but we don't always know the problem unless you bring it to us. So, don't look at a law and say, well, they got a different law. Hey, we can change that if we can get other folks to agree with us, right? If it's needed, we're definitely willing to do that.
And we definitely do look at those best practice states. For this crisis system, for example, we're looking at some other states that have best practices in crisis, including Colorado, Arizona, Oklahoma, a bunch of other places. And I'm sure we will have some things we need you to help us with there. So we are doing that. I just would like to see us start moving in that direction versus we need to step it, I think, to make sure that we can get there.
This is Senator Irvin. Can you hear me okay? I just wanted to follow up with what. Can you hear me?
Yes, ma'am.
Okay, I just wanted to follow up with what Representative Ladyman just discussed. I think it's important for us to have this conversation with as many folks in our legislature as possible as well, because we can't, our state budget all has to work together, and we can't necessarily we have to have all the information available for all of our legislature when they're making decisions about our state budget and about the priorities that we're trying to meet and the targets that we're trying to create. For example, I'm not interested in draining the Medicaid trust fund. I'm interested in making sure that we maintain that so that we can continue to do what we're trying to accomplish here. And so I think it's just very important that we have those conversations as based on the reality of the situations, before we get into the legislative session. So I think it's going to be very important to give this update, no less than to just the Public Health Committee, but have a big, strong effort to try to invite the legislature into that conversation. That's the first thing I would say. And the second thing I would say is, we do have, and I'm grateful to some of our partners in this that provide lots and lots of grants to places all across the state of Arkansas. And I'm grateful for that, but perhaps we can have a conversation where, sidewalks are great and all those different things are great that are being funded by some of our partners in this. But how can we actually just be more intentional and focused on trying to achieve outcomes that really do matter so much for the health and the benefits of all of our citizens across the state? And I think those are things that we have to really focus on, because having healthy babies and having healthy moms and having people that are healthy and stable and mentally that are in a good place just means more success for our citizens and more success for our state. And so how can we have those conversations with a lot of our partners in this so that those programs can be more focused and more intentional. And I don't want to get into, anybody else's business and the priorities they are setting, but they are partners in this with us. So I think it's worth having those conversations.
Well, and Senator, I think you raised an important point there of the critical importance of communication over the next year, because this is going to be an evolving effort. We're working through this. We are learning as we go. We'll continue to learn as we work over the next year. I know in terms of setting these goals, at least where I'm struggling with is trying to balance on the one hand, recognizing that, Representative Lehman, as you said, we want to look to the eagles, not the vultures, and we want to shoot high. We want to not just assume that we as a state are destined to have bad health outcomes. We will work for those better health outcomes, but also recognizing what's the best way to set goals and a method and process that is achievable and that will drive regular improvement in the coming years. And that's the balance we want to strike. But those are all important points that y'all are raising. Thank you.
If we're done with that discussion, I think we're going to move on to the strategic plans portion. Just as a reminder, the ARHOME statute calls for the advisory panel to review the annual quality assessment and performance improvement strategic plan for each qualified health insurance plan. ARHOME has 5 individual QHPs offered by 2 insurance carriers. Blue Cross has 2 plans. That's Blue Cross and Health Advantage. Centene has 3 plans, Ambetter, QualChoice Life, and QCA. And Matthew Bonetta will be presenting the Blue Cross strategic plan, and he's going to move to the podium so that he can see the screen at the back. And then Kim Suggs will be presenting the Centene strategic plan.
Morning. I appreciate the opportunity to speak on behalf of Arkansas Blue Cross today to share a summary of our 2023 strategic plan. Even though the slides are broken up into specific initiatives, really our key focus is utilizing data analytics and our data scientists that we employ to drive actionable outcomes for each one of these particular initiatives, and really use that data to hand off to our care management team, to our provider partners, and to our community resources, so they have that available in order to make actionable plans that are member specific and very targeted to show those improvements that we hope to see reflected in the data that was shared today, but also that really impact the lives of our members. And starting off with preventative care and health screenings. And I wanted to start off with this one today because it really is foundational for a lot of the other work that we do. We feel that preventative care is so critical for us to be able to basically establish that baseline for our members to ensure that they're getting those needed services on a regular basis. So much of what we see that dovetails into more chronic conditions is a result of preventative measures not being met. So this is a critical part of what we do in terms of our incentives. I won't go through each one of our incentives in great detail, but I do want to call out the importance of scheduling that annual wellness visit. That again allows for both the development of a relationship with a primary care provider, but also sets up our members to ensure that they have an understanding of what their health conditions are, so that when they're communicating with our care team, they understand, as we're developing that care plan out with their primary care provider and their other providers that they see, they understand where their healthcare journey is going and what is needed on their part in order to improve some of those measures. So we use a lot of that data in order to feed that into our care management team when they're establishing those plans. But realizing that we're dealing with 19 up to 65-year-olds, how we engage with them needs to be distinctive and really meet their needs. So it can be very traditional in terms of a telephonic approach around a one-to-one when working with our care management team, but also increasingly using digital applications as a way to engage with them. Those digital applications never sleep. They never take a day off. They're available 24 hours a day, 7 days a week. And using those to provide an additional outlet for our members to be able to access care at any point, at any time, but also additional education on what they may need in order to feel comfortable with what the next outcomes are. So using various different tools for our customers to engage in the healthcare delivery system. Telehealth was mentioned earlier. That's a great opportunity, but also there's a lot of apps and services that we employ to provide those to our members so that they are able to do some self-education, but also feel like there's someone that they can work with at any time. And I think that helps from a patient engagement perspective and encourage them to meet those preventative goals and ensure that we're closing as many of those quality gaps as we can as they relate to preventative screenings and healthcare screenings. On the next slide, discussing improvements around maternal and child health care. And really, our goal for our special delivery team, which has morphed over the last several years to have a subset of that team really focus on high-risk members. And when we look at our moms to be in the realization that they were high risk oftentimes before they became pregnant. And so the healthcare conditions that they're focused on a lot of times fall to the wayside as they put more effort into focusing on their prenatal care. But really you have to look at that holistically to make sure that we're treating them for behavioral health issues, that we're screening them for any social determinant issues, in addition to encouraging them to get that prenatal care to ensure that there is a positive outcome as we can and ensure that their healthcare needs are met while the prenatal care is also being delivered. That also sets them up from an educational standpoint around what needs to happen postpartum. And how critical that is, since we see in our data that a number of our members, if they have one pregnancy with us, they have a high likelihood, if they're going to stay with us several years, they will have another pregnancy as well. So getting out in front of those health issues and in trying to move them back from a high risk perspective to more of a managed condition point of view allows for those interventions to really take hold. And it doesn't get to be where they cannot focus on their underlying health issues, but they're looking at it in a totality. And that's really what our team is charged with, that high risk team, is to managing those chronic conditions that the member may have, but also ensuring that we're having as healthy of a delivery as we possibly can. And that carries into more of a day-to-day treatment perspective, and they're able to use that and understand the services that they have available to them in their communities, as well as what we as a carrier can provide to them as well. So what we overall look to incentivize, of course, is working on a one-to-one relationship with our care management team. That's why that's one of our chief incentives, but also having those recommended pre and postnatal care appointments, making sure that they're meeting those and ensuring that they're seeing those consistently. The data definitely reflects back in terms of the positivity of that and what that means for our members, and then what that means from a positive delivery. And the next one around improving behavioral health. This is really a focus of ours from an enterprise perspective. The ARHOME population is a key part of that, but really what we're looking at for Arkansas Blue Cross is how we can influence and improve behavioral health outcomes across all Arkansans. And this is definitely a top three thing for us as an enterprise around importance. And really it starts with member outreach. And again, going back to utilizing a lot of data analytics to understand so many of our members have comorbid conditions. They have both underlying health issues, but also that behavioral health diagnosis. That behavioral health diagnosis oftentimes makes it very challenging for them to manage their health conditions. They're not able to focus on managing their health conditions because the behavioral health diagnosis is not being addressed. It could be because of social determinant issues. It could oftentimes be coupled with a substance abuse issue. So really looking from a head to toes perspective is the only way truly to address those underlying health conditions for that member, is to also couple that with their behavioral health needs. So we can't segregate the two. And that's really our care management approach, is to work with them across that spectrum of conditions that they may have, to have a very tailored approach to them, work with those community resources for them, make sure they have an understanding of what's available to them where they live, but also those health care services that are available, as we partner more and more with the behavioral health centers throughout the state, and make sure that we have that plan in place. And two of the incentives that I want to specifically call out, because I think they're so important, is the follow-up after hospitalization for substance abuse and follow-up after hospitalization for mental health. Incentivizing members to see that treatment and seek care within really a week period of time is important from preventing them from having a relapse, ending back up in the emergency room, ending back up in an inpatient stay where they have to be stabilized again. So encouraging them to do that and seeking that care, and then helping them find those resources that are available to them to establish a relationship with the behavioral health provider and or a primary care physician, whomever is in their particular community and area. That's very, very important to stopping that loop of them bouncing from one ED visit to another because they've had another behavioral health issue, or they've not been able to treat their underlying health conditions, and that's caused a emergency department visit, or what worse, an inpatient stay. So we feel like those are so tied together, and it's so important for us to really manage that and provide those services to our customers the best that we can. And these last two slides are, I think, very interconnected in terms of our approaches, and that's to reduce health inequity among our members. Not a simple thing, and there's not one solution to address health inequity in rural and minority populations. We have a dedicated medical director. Many of you know the name Dr. Chriselle Nash, in terms of the work that she's done in the state for years and years and years. And really her key focus in terms of, again, using data analytics and our data scientists to identify where those inequities exist. And then what and how we can empower our members to seek a lot of our community treatments, as well as understanding where those inequities are so that we can address those in a meaningful way. Really lasting improvements in our population. That's really what our goal is. How do we identify them? What can we do to make those changes, and then embedding those changes throughout all of our operations? That could be through our welcome centers, which we have throughout the state, our customer service teams, and generally how we conduct ourselves as an enterprise, keeping in mind the health inequities there, and then making changes to our framework is how we feel like will allow us to identify and adapt our way of doing business so that we can put our members in better position there. Incentivizing, again, really goes back to the first slide, but preventative care, incentivizing a primary care provider relationship. That's really the foundation and fundamental piece of this that we think is critical to us being able to do actionable goals with those primary care providers around changes, and especially as we identify those, being able to provide the data to our primary care providers so that they understand that we've identified something that might benefit them in terms of the treatment of that particular member. And then participating in a health fair or a healthcare community event, anything that we feel like engages our customers more in their community can benefit them in terms of their overall health, but also just generally speaking, has a relationship around behavioral health and also limiting or reducing some of those social determinant factors. And then finally, and this is, like I said, I think they're tied together, but reducing the proportion of our ARHOME members living in poverty. There's no really easy solution to this one. Like the previous slide, there's a lot of, again, social determinant issues that play a role in this, but our focus really is around how do we improve access to educational classes or additional classes that will help towards a trade that will allow our members to either seek a job if they don't have one right now, or improve upon the position that they do have in order to help them move up the economic ladder, put them in a better position where they can be successful. We also leveraging what the Department of Workforce Services has around educational certificates to be able to incentivize those as well. We feel like that's going to allow our members to have a leg up from where they stand right now. And then again, utilizing our social work team, which is scattered throughout the state and really lives in the communities that they serve, as well as our care management team, to educate our members around the services that are in their communities. Oftentimes our members are ignorant of what's right down their doorstep. And I think that's a key part of what this initiative is again, using our data that we have and the data that we're able to pull together, and sending that to our teams that are in the field so that they can educate our members in a meaningful way that will hopefully improve their overall economic and health outcomes. So I appreciate the opportunity to speak to you all today, and again, give you a summary of what our 2023 plan is for the ARHOME population, something that we continue to evolve and analyze on a regular basis so that we can improve the overall health and well-being for our Kansans and the ARHOME population. So thank you.
A question. So I'm impressed by the fact that y'all are assessing the social determinants of health, particularly for those high risk, high utilizers. Do y'all have a staff assigned to work with these high risk, high utilizers in addressing their social determinants? And if so, how do they go about doing it?
So I think first, they're able to understand, again, since we don't have them centralized, they live throughout the state. So their evidence of understanding what's available to them is because they live in the communities that they serve. So they know what our members are going through because they live in that same area. So they have those experiences. But also we have increased the number of data scientists, master level data scientists that we employ by 15, 20, 25% over the last couple of years alone, and utilizing more data scientists, artificial intelligence, and then predictive analytics to determine from data that we're able to pull in from other sources, coupled with the health data that we have, gives us a more well-rounded profile of what our customers have, so that we can determine what they may need from the data that we have, and then give that to our folks that are sort of living and breathing it with our customers every day. We feel like those coupled together allow us to better direct the social determinant issues of our members, or at least put them in a position where we can point them to services if we're not able to provide, and make them aware of those as well.
So somebody at your analytic division pulls this information, gives it to the care coordinator. Do they do a telephone follow-up or?
So they can. So they can do a telephone follow-up. They can do a face-to-face in some instances. They can text. They can point them to our app or one of our vendors' apps that might be available 24 hours a day, 7 days a week. So really, we don't want to limit it to one medium with which we engage our members. We want to have multiple different options to meet their needs at the time that they need it. We know a lot of times it's not convenient to meet with someone at 10 o'clock in the morning because they're working. So being available to them at 7 o'clock at night after they've picked up their kids and had dinner, et cetera, that's what we want to be able to do and provide to our customers, is to really meet them in their needs when they need it.
Thank you.
Yes, sir.
I believe Senator Irvin has a question.
Thank you so much. Appreciate your presentation. So a little bit like two different things. One is I appreciate what you said about utilizing all the resources that are available to individuals. One of the things that I think we underutilize is our extension offices that are located in all 75 counties, where, you know, through University of Arkansas Extension Services, we have a lot of education classes that are available to people for free on nutrition and exercise and all different kinds of things. And so I think that is a resource that is underutilized, because we're not connecting everybody into this, you know, kind of moving all in the same direction. And how can then we leverage those different resources and maximize the benefit of those programs? And so that is one program that I'm really want us to focus on, you know, utilizing our extension services and our extension offices that are, like I said, in every county in rural Arkansas. You know, those extension offices are very, very active. And so that's one thing that I would just say. And then the second thing is I'm not sure if you have, if you offer grants for maternal classes. Or if this is something that y'all thought about. If we're trying to really focus in one, you know, y'all I think have supported Silver Sneakers programs in the past for our elderly population, which is great. Y'all have given a lot of grant money across the state for walking trails and things like that, which have been great. I'm just curious if y'all would be considering or something that we can maybe discuss as being more of an intentional focus into maternal care and prenatal care and those types of things. I think your statement that these are high-risk individuals before they even move into pregnancy is absolutely correct. And so I'm trying to, how can we leverage all of our resources together to be super focused on, you know, like this population, to really change our outcomes when it comes to maternal and infant mortality and health outcomes. What are your thoughts about that?
Yeah, first, thank you. I think that's a great idea around the cooperative extensions. I'll definitely take that back to the team. I don't have off the top of my head the grants that we've provided around maternal care. I know we have done some of that work, but I think talking through that more and understanding where our opportunities are from a grant perspective, or just how we can make changes in terms of who we're engaging with, or in sort of what circumstances. I think we're very open to having those conversations and understanding some of your ideas and feedback, and how we can maybe approach those and turn those into practical, actionable ideas.
Yeah, no, I think we should, because I think it'd be beneficial for all of us. And then I think as well as you being a partner in this program. And so, because if it improves all those outcomes, it's an improvement for all of us. And gets us to where we want to go and assist y'all in reaching those metrics that I think are going to be very important. So, let's just really try to focus on that, after the first of the year. Let's have some meetings about that specifically. And this is not just for you, it's for the other partners that we have in this space. So, I look forward to meeting with all of you and figuring out what we can do to really leverage all of our resources together to be more intentional, specifically about this population, because they're so locked together with mental health and maternal and infant health outcomes. Thank you so much.
Yes, ma'am. Thank you. Thank you again.
Next up is Kim Suggs from Centene. And again, Centene has 3 of our home plans, and better QCA and Qual Choice Life. Okay. All right. Hopefully I can see from here to there. So again, I'm Kim Suggs. I am the Senior VP of Operations for Arkansas Health and Wellness, and provide oversight on all 3 of our QHPs. Thank you. Oh. Okay. Maybe. Oh, down. There we go. All right. So what I'm going to talk about today is a lot of our programs, incentive plans, the things that we do within our organization to encourage our members to take an active role in their health. So what my presentation today actually kind of incorporates our strategic plan along with some details around both our member and provider incentive programs, as well as other programs we run within our organization that target these specific goals. So our plan really is around the 2 program goals of this particular ARHOME waiver. One, we've talked about a lot: improve the health outcomes of our ARHOME participants through use of incentives, specifically maternal infant health, rural health, behavioral health, and then those suffering from chronic diseases, as well as incentives to support our participants to move out of poverty and up the economic ladder. I will not bore you with all this detail. This really is more details into our what we call our quality assurance and performance improvement program, or as we like to refer to it, is the QAPI. So every year we do go through a very detailed process to develop our QAPI program, which outlines all of the activities and incentives that we are going to target and implement in the upcoming year. This actually comes straight out of from our MOU and also out of the waiver. All the things that we know we have to address in some way are outlined in the QAPI. So we'll get past that to some better stuff. So activities around incentives. Obviously, we found that in order to get a lot of our members to take actions, incentives are a really good way to make that happen. So as we talk through this, we're going to talk about what we've done in 2022. All of these activities will continue into 2023, and then we'll talk about some more programs that we do plan to implement in the upcoming year. So My Health Pays is our member rewards program that we're going to talk about in detail. We also have community health fairs, screenings. We have provider incentive programs that we call continuity of care, and then also a provider incentive program around in-office assessment. So again, as Matthew pointed out, getting members in to see their primary care physician is very key. Getting them to close
those open gaps that we know they may have. If they need to have breast cancer screenings or cervical screenings, that primary care physician is very key in driving those actions. So if we can get members in to see their primary care, then we have crossed the first hurdle for sure. So some details around our My Health Pays incentive program. It truly is a financial incentive program where members can actually do different activities. Some may be actually visits, having flu shots. Some are actually more incentives around walking incentives, challenge incentives, and then also just even as we'll see as we go in, just watching educational videos actually earns them points. So they earn points that they can either use those points to shop in an online store, or they can convert those to dollars. And then they can use those dollars for things like their co-pays, paying those that we've talked about. They can also use them to pay their utility bills, their phone bill. They can even help pay toward their childcare or rent. We educate members in many ways about our My Health Pays program. We are constantly posting on social media. We send flyers. We talk about it at our health fairs. And we have a lot of outreach programs just to educate members on if they have open care gaps and we're trying to get them in to have breast cancer screening, for example. We would also always tell them about the rewards they can earn in the My Health Pays program for either that specific topic we're speaking to them about or any of the other incentive areas. These are just some examples of what that looks like. This is actually details in how they are incentivized. So you can see there the number of points that they can actually earn for these different activities. They can earn up to 5,000 points a year, or equivalent of $500 in their My Health Pays incentives. And you can see some of the things that are rewarded higher are the things that we really want to engage these members in: a well-being survey or a health risk assessment. If we can get them to complete those components, it helps us to better understand the members, where their risks are. And then as we're looking at who we need to outreach to for various different programs, those health risk assessments really help us with that. And then you can see there's other incentives for screenings. Breast cancer screening is one. You can see there cholesterol screening, various different ones. In addition, we have what we call quarterly challenges. These are challenges are online through their member portal. So when they log into the portal, they have the opportunity to go into these challenges. These are really educational challenges, so to speak. So they watch videos, they understand, and they can go through and they have to complete the entire segment in order to get the points. So it might be 7 or 8 different educational components within the quarter that they can complete to get the points. So like smart money behavior for summer challenge, that was a summer program last year in this year in 2022. And you can see what it talks about: where your money goes, save money when you shop, how to increase your savings. So really targeted towards some of the economic challenges that our members have, as well as even wellness. There may be a whole wellness challenge. And then we have what we call power-ups. These are also online, various educational videos that they can watch. These are not like the challenge, you have to complete the whole entire set. These are individualized. So, and you can see they range from all kinds of health education to behavioral health, mental health education, to even debt savings and those types of information. This basically is, again, just how they earn points. This is in 2022 up through the end of June. This is how the amount of money we have paid toward the clinical components of the My Health Pays program. You can see we're just over $500,000 we've paid out to our ARHOME members for completing these activities. My Health Pays really is like a credit card. The money gets loaded onto a Visa type card that then they can use that card to, again, pay their premiums, utility bills, etc. So they can make that decision to move that to cash, or they again can just pay or use those points in the online store. In the store, there's things like the walking trackers, those kind of things. Other healthy type items that they can purchase through the store. This is speaking to our community health events. You can't actually see it. It's kind of covering part of the top up there. But we do host several community resource fairs throughout the state every single year. Of course, during COVID, those kind of got put on hold, but we're starting to get that back going in 2022 and plan to do again more in 2023, hopefully back to our pre-pandemic levels. At our community health fairs, we do all kinds of things. We do a lot of screenings. We invite providers we partner with in the community to come on site with us. And while we're there, we're doing testing, educational things. We have mental health providers that do depression screenings, all types of healthy behavior activities and education that goes along at these events. Again, we hold them throughout the state, throughout the year. This particular one had 250 of the community members attend, and it is open to the community. We don't limit it to just our home members, but we do invite all of our members specifically to come out to the events, but we also do allow anyone within the community to attend. We also have provider incentives. We have two main programs that we currently are running. One, continuity of care program, where providers are incentivized for engaging and addressing chronic conditions within their population. So they're really focused on those chronic conditions that their members have. We provide them information about that. So if we, through our data analytics, can provide the providers back information about the chronic conditions of their members, we do that. We do that in various ways. But through our provider portal, they're able to see that information about their members. We also have an in-office assessment program. Again, providers are incentivized there for engaging and addressing just gaps with their population. These two programs, well, it doesn't look like the second one is actually paid out much. It's because it just hadn't been completed for the year yet. So those will typically result in a lot higher payout. When we're able to report the entire year, you'll be able to see that. All right. So additionally, we include initiatives to support the economic independence. We've talked about some of that, and that's incorporated into our My Health Pays, but we've also been working with the Little Rock Workforce Development Board to ensure that we can share information that they have already developed. They provided that to us and that we can share, email it out to our members if we so desire. And we also invite them to attend the health fairs with us. So they did come out and attended. That was very well received, where they can actually have a booth at our health fair in the community and then be able to share that resource information directly. And then we talked about the challenges and power-ups. We really see our members take advantage of these. Again, they're educational in nature, but you can see just through the first half of this year, we'd already paid out almost $1.2 million in incentives to the population. So this is one where we do see a lot of uptake from the membership, getting in there and going through these educational pieces and earning those points. again, we talked about the Workforce Development Board partnership that we have been working to cultivate. This is just part of the strategic plan, just saying we will meet our requirement to provide a strategic plan and reporting. And then again, as we've talked about, our focus areas for around our quality and performance metrics, again, primary care, maternal health, chronic conditions, behavioral health, specifically with treatment for mental illness and substance abuse. And then we've talked about our quality and performance metrics. Obviously, we just talked about incentives, provider and member education incentives, the in-office incentives. And then we also have some additional programs that we utilize to target these populations. We'll talk about those here in a moment. Okay. Here we go. It's like I'm pushing the button, it's not moving. So when we talk about our individuals that are pregnant, so we have several things that we do to target this population. We first encourage our population to complete a notification of pregnancy. That's an assessment that members can fill out in various ways. They can do it either through their portal online. We do outreach when we are able to identify an individual that may be pregnant. We can take that information over the phone, but it really helps us to understand whether or not the individual has high risks. And then if they do, we then try to enroll them into our Start Smart for Baby program. That is a case management program designed specifically for high-risk pregnancies, where we have case managers that work with those individuals throughout their pregnancy to make sure that they're attending all of their visits that they need to, making sure they're getting all the testing that they need to get. And it is an individualized, person that they are able to call with questions should they have any, but that's through our case management program. We have a lot of uptake on our Start Smart for Baby program. One thing we also just implemented this year and hope to expand on it in 23 are community baby showers, where we actually go into a community. We invite all the pregnant moms or those moms that may become pregnant to come out and attend these baby showers. They do sound just like that. They're kind of fun, but they get us an opportunity to have a direct contact with that member and share why going to all their prenatal appointments is important, but they also even allow us to bring out folks from the community that shows them how to install their car seat appropriately. We talked about the notification of pregnancies. You can see there in 2022 through June, we already had 1,658 individuals that completed that. Again, some more details there just about our Start Smart program we talked about. You can't see the number, but it does say there. We had 632 individuals that are active in the first 6 months of the year in our Start Smart for Baby program. Again, those are primarily the high-risk members. You can see here just some details about our first community baby shower that we had earlier this year. We've had a second one since the presentation was put together, but the first one we held was at down in Pine Bluff at the community center. And you can see we did invite 600 people. I think this is demonstrative of what it takes to get folks to come out. We invited 600 people. We educated them about what the event was for. We had 45 agreed to come, and then only 20 attended. So for our first one, it was a good learning experience to kind of understand how many we need to invite and how many we can get to attend. But again, we've had a second one in Morrilton earlier in November, and we plan to host at least 4 in 2023. We also offer a digital case management application called WellFrame. The digital is 24/7 opportunity to access our information. You can also connect to a live person through through the digital case management application, but it is on your phone. It's an application. It has various modules that are specific for the various items you can see listed there: maternal health, chronic complex care, behavioral health. So pretty much covers most anything an individual would be interested to learn about. But it is a lot of education, information. They can ask questions, and then they can connect to a real case manager if they would like. This one, again, just some additional information about some of the folks we've partnered with to help bring education to the population. Again, just more information there about our case management programs. We do have a behavioral health case management program. This speaks to that, that is targeted toward individuals with depression, anxiety, bipolar, all of those serious mental illness conditions that we've been talking about, and we have quality measures around. You can see first half of the year, we've had 468 folks participate in that case management program. Basically the same. And then we have what we call a HALO program. This program is evidence-based program that supports members that have risk for substance misuse, substance disorder. It's a program that, again, it utilizes data, identifies individuals that have a condition that would put them and meet criteria to be in this program. And then it is a lot of education and follow-up outreach with our case managers. We have 2 case managers specifically hired to just run this particular program. We have a pharmacy lock-in program. This program is very effective as well. Individuals that meet criteria get locked into a specific pharmacy. So folks that are, visiting multiple emergency departments, going to multiple pharmacies, they exhibit those types of criteria that then we do lock them into a single pharmacy, meaning they can only fill one place. Now they can change that if they have a valid reason, they've moved. Obviously, we would want to change their pharmacy, but we do find that really helps to reduce members from basically, getting drugs from multiple pharmacies or multiple emergency department visits, etc. We have specific SUD case managers focused on those individuals that meet that criteria. And then again, just lots of educational opportunities. We'll go through these things we've already mentioned and talked about. Okay, in 2023, so in addition to all of these programs that I just ran through, we do have some additional programs we are implementing. One is a value-based program with a vendor called Quartet. That is a behavioral health program. It will incentivize providers. So it is looking at behavioral health providers and looking at incentives that we can put in place with those providers to ensure that members are getting their follow-up visits. A lot of times the issues with that is not that the member may not seek that follow-up visit, it's actually being able to get an appointment in a specific amount of time. So these programs will target those kind of opportunities with providers to ensure that those members are able to get in, they're able to get the appointment and to see a provider in a timely manner. We have Choose Tomorrow, a new program we're implementing on suicide prevention. And then we're looking at more partnerships with our rural health centers and co-branding with those providers in the communities as we go out with our in our community events. Same My Health Pays, really no difference here. Each year, this My Health Pays program can be tailored. So it can be tailored to any of those activities that we see we need to put a little bit more focus on. We can add new activities. And then the challenges and power up topics, those change on an annual basis as well. We just talked about the value-based program with Quartet. So I won't go through that again. We have what we call a METS program. That's also care case managers that are targeting individuals that meet certain criteria around their behavioral health needs. Choose Tomorrow's suicide prevention program, and then partnerships. All right. Any questions? A lot of detail, I know. As you can see, we do run lots of programs, lots of programs, lots of incentive opportunities. We work very hard in trying to get members to take action. Obviously, each population is a little bit different. Each member is a little bit different. How you outreach to them based on age is also different. We have found. So as we learn more and more in areas where we need to target, then we will continue to tailor our programs to focus in those ways. So, all right.
This is Senator Missy Urban. Sorry, just have a quick question. If you can hear me.
It's Senator Urban.
Go ahead.
Okay. So I appreciate, one is I'd love to be able to review your different videos that you have available for those different power-ups and things like that. So I appreciate the money management videos. I think that's an interesting approach, and I do appreciate that. So I'm not sure if I would be able to review those, but I would really like to, just because I think it might be something that we could connect through like our financial literacy commission that we created. And, you know, again, how can we just continue to leverage all the different things that we are paying for in programs and put it all in the same vehicle and leverage those resources to be more effective. So how can we connect all these different approaches together? And then second, on your provider incentives, I think it's just important for me to make this statement because I know that there's a lot of evidence-based, you know, programs out there and quality programs and things like that. But it really just comes down to the fact that in primary care model, primary care, they make their money by seeing volume of patients. They're not surgeons. Surgeons make money in surgery. Primary care makes money by seeing patients. And so they do not have time, to be quite frank, to be data collectors for entities. And if you do not have incentives in place that provide for them to be meaningful in that kind of engagement, it's just not going to happen. So if we really are wanting to get more preventive wellness visits or clinical screenings, then you need to pay more for those. I'm just going to be frank about that. And so until we kind of understand that, you know, we're always going to be behind the 8 ball because the primary care physicians, primary care providers, whether they're nurse practitioners or nurses or physicians, that model of medicine and the way it's paid is just not in line with what we need, which is they need to be able to spend more time with these patients that are really at-risk patients that need more time with them. And so, you know, and that time is not compensated at the same time at the same way as a surgery is. And so I think we just need to have a real conversation about that and how we structure these things so that it's meaningful engagement. So those would just be my only 2 comments. I really do appreciate the presentations. I really am looking forward to seeing these videos because I'm really interested, especially in the debt management portion of that. So thank you so much. Those are just my 2 things. Thank you.
Sure.
I like the holistic approach that both of you took. The holistic approach, because health is related to income and social and all that. Because when I look at Massachusetts, I believe I've got my numbers right. I believe they're number 1 in healthcare. You know, the biggest thing is per capita income. They're number 1. We're like 49th. So, you know, not much you can do about that. There's some things we can do to increase our income through new businesses and better businesses. But I like that approach. The second thing is getting people there, you know, and you have incentives to do that. And, you know, that's the biggest thing. How do you get them out there? And I like some of the stuff that y'all had on there. So thank you.
Thank you. Yeah, I think we will all agree that you're right. Getting them there, that is the first hurdle. And encourage them, you know, individuals to use of incentives, and then also incentivizing providers to also outreach and try to get those members that are on their caseloads back in. And then when you do get them, you know, make sure that that visit is, you cover as much as you can in that visit, even if it's a sick visit, if they've not had wellness, that you're talking to them about that. So lots of incentives. So I appreciate those comments, and definitely can get some access to those videos if folks want to see those.
Thank you so much. Any additional questions? All right. Well, thank you to our carriers for your presentations today. And thank you to Nell Smith and Dr. Golden for the presentation on the outcomes. And for the panel members, thank you for your attendance and for your participation. We appreciate you so much. 3 quick things. One, if you parked in our visitor parking, Courtney can validate your parking so you can get out. Number 2, for our next meeting, we were looking at, it's in March. We know that of course legislative session will be going on. We're looking at possibly a Friday afternoon, 1:30, either Friday, March 10th or Friday, March 31st. So particularly our legislative members, if y'all can just give us some feedback on what might work better, we would appreciate that. And then one last thing, of course, we know we may have some additional turnover in our membership after the chairs are named in the House in January. But we know for a fact we're losing one member. Representative Michelle Gray she is ending her term and leaving the legislature. And so for her participation on this board, but also because she was one of the lead sponsors of this legislation, we have a plaque for you just as a token of our appreciation. Thank you for your work around our home. We just appreciate you so much. All right. And with that, unless there's any other business, I believe we are adjourned.
Recording stopped.